The act of performing a patient handoff between nurses at the bedside in the presence of the patient, also known as bedside shift report or bedside handoff, is a standard of care utilized to great effect across healthcare. The benefits of utilizing a bedside handoff have been studied and proven time and time again. You've probably heard the main bullet points. Patients are able to stay informed and take an active part in their care. Shift change has the highest incidence of adverse patient events, so by putting eyes on the patient during report, you ensure their safety. But still, convincing nurses and PCTs to perform bedside handoff as part of their standard practice is often met with resistance. Why is that? In this video, we will explore some of the common complaints, fears, and misconceptions surrounding bedside handoff, as well as review some of the main benefits of the process. First, what should a good bedside handoff consist of? Think of what you would want included in a report you would receive while sitting at the nurse's station. Most of that can and should be said at the bedside. Plus, you get the benefit of being able to visually validate a lot of that information during report. Introduce yourselves and take the time to manage up your team. Identify the patient and give demographic information like age, diagnosis, code status, etc. What are the current issues keeping the patient in the hospital? Include any pertinent health history, lab results, vital trends, consults, etc. What's going on with the patient right now? Include pertinent head-to-toe assessment information, IV lines, wounds, medications, infusions, etc. What is expected during the oncoming shift? Consults, tests, etc. What should the oncoming nurse anticipate or follow up on? The components of an SBAR report are something you are likely very familiar with. On paper, moving that conversation from a nurse's station to the patient's room doesn't seem like a difficult task. But for some, the change in practice presents a number of perceived barriers.
Not everyone wants to do a bedside report, and I feel uncomfortable telling another nurse what to do.
What if the patient is sleeping? They probably don't want to be woken up for a report.
What if there's family present? I don't feel comfortable saying these things in front of a family member. The patient probably doesn't want them to know everything.
The patient is going to have questions, and I won't be able to get through my report.
There are some things that I just don't feel comfortable saying in front of the patient.
What if they don't know something yet? It's not my place to break sensitive results to a patient.
For isolation patients, I don't think it's worth donning all of this PPE just to give report.
Should I go into the room if the patient is confused? If they don't understand the report, what's the point of doing it at the bedside anyway?
This is going to take more time, and I don't have much time for this.
Let's take a look at these barriers and some strategies that can be used to overcome them. Hey, Kaylin, I'm here, and I'm ready for a report. Do you want to meet over by 3120?
You know, it's been a really long and busy day. Do you mind if we just sit and do it at the desk?
Sure. I guess so. It can be uncomfortable asking someone to do something they don't want to do, and that's understandable. But performing shift report at the bedside is a requirement at Trinity Health Livonia, so you aren't asking anyone to do anything extra. And maybe the easiest way to avoid this problem is to not ask at all. Hey, Kaylin, I'm here and ready for a report, so I will meet you by 3120 whenever you're ready.
Okay.
Bedside report isn't a request or an option. It is a requirement and an expectation. Let the previous shift know that you are there, and then continue to take the report to the bedside where it will be held. You may be hesitant to wake a patient up for report, or to speak in front of visitors, or you may be concerned that the patient will interrupt report with a barrage of questions. These issues can mostly be solved with good communication between you and your patient. You can eliminate the assumptions that the patient doesn't want to be woken up or not want their information discussed in front of a visitor. Just ask them what they want, ideally upon admission. So we give report twice a day, and that's when we hand off from one nurse to the next. We call it bedside handoff because what we like to do is be in the room at the bedside with you, kind of doing an assessment at the same time, but also talking together, talking with you, making sure that you know what's going on with your care, what's going to happen in the future, what we're thinking, and try to get you involved. But I know that there are times when you're probably going to be sleeping during report. Would you want us to wake you up for that, or would you rather we let you sleep when we do report out in the hallway?
You can wake me up. I'd like to stay informed about what's going on.
Excellent. And what if you have visitors present when we need to give report? Do you want them to stay and listen to everything, or would you rather we ask them to respectfully leave the room? Or are there some people that you would like to stay and listen to report, and other people you'd like us to ask to leave for a few minutes? It should only take about 5 minutes for report.
If my daughter's here, it's okay if she stays, but if anyone else comes in, I think I'd like them to step out.
Okay, perfect. We'll make that happen. By asking the patient ahead of time what they want, you can eliminate those barriers that are created by our assumptions of what we think the patient wants. If you ask this on admission, it is information that can and should be included in those bedside reports as we hand off from shift to shift. You can also include the patient's preferences on the whiteboard, as was shown here, so the practice is continued per the patient's preference. If you don't get that information in report, ask the patient at the beginning of your shift, but always ask the patient what they want. Never allow assumptions or your personal feelings to drive your practice. Concerns about the patient interrupting report with questions can also be mitigated by good communication, either upon admission or just at the beginning of every report.
Mrs. Silver, this is Mark. He'll be taking over as your nurse. Before we start report, is there anything that you need, or do you have any questions?
Oh no, thanks for asking.
Great. Well, if you think of any questions while we're giving report, if you can, please try to wait until the end.
Okay.
The potential problem here is that you may have just opened yourself up to answering 50 questions once your report is finished. But again, clear communication and setting boundaries will mitigate these issues.
Okay, I have a lot of questions.
That's great. Let me write them all down, and then I am going to have to go get report on the rest of my patients. It'll take about 15-20 minutes, but as soon as I'm done, I'll come back and we'll go through all of your questions and I'll answer them to the best of my ability. Does that sound okay?
Okay. Thank you.
It's easy to look at questions as an interruption or inconvenience, especially when you've just started your shift and you have a laundry list of things to do. But questions mean this patient is involved in their care and taking an active part in it. That's what we want to achieve. So questions, although potentially time-consuming, mean we're achieving one of the goals of bedside handoff. Also, it's easy to assume the patient will have a lot of questions after hearing a report. But if bedside handoff and purposeful hourly rounding are done regularly, the patient's questions will have been answered during previous encounters. The more consistently bedside report and hourly rounding are done, the more well-informed the patient will be, and you will run into less and less questions with each report. Staff are often concerned about the discussion of sensitive information in front of the patient. It's common to think there are some things that just can't be said in front of the patient. And where that is true in some cases, it's less common than you probably think. Reflect for a second about the information you don't think is appropriate to say in front of the patient. Is it truly relevant to the care of this patient? Or is it based on personal opinion or feeling? Or is it based on fact? Do you not want to say something because you would feel embarrassed saying it in front of the patient? Or because it's not the nurse or PCT's responsibility to give that information to the patient? If it's something you would be embarrassed saying, it's likely not important to the patient's care. Maybe you have an anecdote or personal feelings that would reflect poorly on the patient. If that's the case, no, you shouldn't say that in bedside report. And it isn't necessary in any other form of report either. It's not relevant to this case. If there are test results or other findings that you don't know if the patient is aware of yet, then yes, this does present a bit of a barrier. That is information that is important to the patient's case, but nurses and PCAs should not be the ones to break that information to the patient. That is the responsibility of the physician. This is where a hybrid approach is needed for report. Say the medically sensitive information away from the bedside, and then give the rest of report at bedside. You can have a short discussion in the hall before entering the room when this is the case.
Okay, this is Mrs. Silver. She came in with complaints of chest pain, and she had a stress test today that showed some significant ischemia. But I don't think the doctors have talked to her about that yet, so we won't bring it up while we're in the room.
Cool, let's go. If the patient is in isolation or is confused, or with a variety of other situations, it's not uncommon for staff to avoid bedside report. Maybe staff don't want to don or waste the PPE needed to enter the room. Maybe they don't want to disturb the patient because they seem like they're content. Or on the flip side, maybe the patient's agitated or restless and you think it will make report take too long. With isolation patients, put on the PPE and get in the room. First, there is no need to be concerned about wasting the PPE. It's not a waste, as bedside report is a valuable process. It's worth the time, and it's worth the PPE. Secondly, bedside report is a benefit to both us, as nurses and PCTs, and to the patient. Just because a patient is diagnosed with an infectious agent, it should not mean that they are deprived of one of the standards of care afforded to all other patients. Staff will already be going into the room less often than a non-isolation patient. Make sure report is not another time for this to happen. With confused and agitated patients, it's understandable to not want to agitate the patient further. But also remember that shift report is the most dangerous time for patients. It is proven that adverse events occur more frequently during shift change. Although there are twice the staff on the floor, the patients tend to receive less attention, leading to falls and other injuries. The confused and agitated patients are arguably at a higher risk for these issues already. You need to lay eyes on them and assess their safety at this time. Be in the room, checking the patient, and giving your report. Finally, one of the most common concerns is the time staff think it will take to give bedside report. It may end up taking a bit more time, but there are strategies to get through that as well. A lot of the added potential time comes from issues we have already discussed, and if you take the opportunity to communicate and give clear expectations and boundaries to your patient, you can minimize or eliminate that additional time. Another important thing to do as the off-going staff member is to round on your patient before shift change and address any immediate needs at this time. That way, you will minimize the chances of coming into a patient that needs to use the restroom, or needs cleaned up, or wants a glass of water. Sort those things out beforehand so they don't become issues during report. Utilizing some of these strategies, let's take a look at an example of a bedside handoff. Hey, Kaylin. I'm here and I'm getting all your patients today, so when you're ready for report, I will be over by 3112 and I'll meet you there.
Okay, be right there. All right, this is Mrs. Silver. She came in with difficulty breathing and CHF. She had an echo yesterday, and the results came back last night, showing an EF of 15%, but the doctors haven't been in to talk to her about that yet, so we won't bring it up while we're in report.
Okay, sounds good. Let's go.
Hi, Mrs. Silver. Let me help you with that.
Thank you.
I'm going to be leaving for the day, but this is Mark. He'll be your nurse,
Hi.
And he's going to take great care of you.
Okay. Thank you.
We're going to give our report now, but before we start, do you need anything or do you have any questions?
No, and you just took me to the restroom, so I think I'm okay.
Okay, great. If you have any questions while we're doing report, if you could please wait until we're done to ask them, that would really help us, and then we'll do our best to answer everything.
Okay.
Okay, can you please tell us your name and date of birth?
Jane Silver, 2/20/1948.
This is Jane Silver, 75-year-old female, born February 20th, 1948.
And I have Jane Silver, 75-year-old female, born February 20th, 1948.
She was admitted to the hospital yesterday for difficulty breathing. She lives at home with her daughter.
Excuse me? My daughter lives with me.
Right. I'm sorry. Her daughter lives with her at home. She has a history of CHF, CKD, diabetes, and hypertension. She has an allergy to amiodarone, and she is a full code with an advanced directive on chart. She is alert and oriented ×4, and she's on 3 liters nasal cannula of oxygen.
Let me check that real quick. All right, 3 liters looks pretty good. Mrs. Silver, do you use any oxygen at home?
Oh, no, sweetie, I don't need this at home.
She's on telemetry with normal sinus rhythm. Last blood pressure was 135/86, and she denies any chest pain. She has 2+ pitting edema in her legs. She had an echo done yesterday, and the doctor should be through today to go over the results.
Mrs. Silver, we're just going to take a real quick look at your legs.
Yep, this is how it's looked. She's receiving 40 milligrams of Lasix BID, and she has good output in her Foley catheter. She has strict eyes and nose ordered, but the Foley was put in for urinary retention.
So the Foley's over there?
Yep. She's had 2,100 mLs of urine output in her Foley over my shift, and it was just emptied. Her last BM was 2 days ago.
Okay.
She has coarse lung sounds with an expiratory wheeze and a non-productive cough. She gets short of breath with exertion.
Mrs. Silver, I'm just going to take a quick listen to your lungs, okay? Okay, take a deep breath. And again. And again. And one more time. Thank you.
She's up 1-person assist and uses a walker. She does have an unsteady gait, and she is on fall precautions. She's got on the non-slip socks, the wristband, and the bed alarm is set.
Actually, it's not, but I'll get it right now.
Ugh, geez. I'm sorry about that. Thanks. She's on Lovenox for DVD prophylaxis. Her skin is intact, but she does have a red but blanchable spot on her coccyx. She has general pains and does have Tylenol ordered PRN.
Can we take a look at your back?
Okay.
I'm just going to move your call light out of the way. And then, can you roll on your side for us, please? We'll take a look back here. I don't know. This isn't really blanching, and it looks more purple, like a DTI.
Yeah, you're right. I'll put in a wound care consult before I leave.
Okay, come on back. Mrs. Silver, you have kind of a deep bruise on your back, so we're going to call a skin nurse to come in and take a look at that. But in the meantime, we're going to reposition you a little bit to get some pressure off of that backside. So can you roll over again? We'll put this wedge right underneath you.
Okay.
How are you feeling right now? Are you in any pain?
Oh no, thanks for asking.
Is that comfortable?
Mm-hmm.
She has a left forearm 20 gauge and a right forearm 22 that are both saline locked.
All right, Mrs. Silver, I'm just going to take a quick look at both of these IVs. And over here. All right, I'm going to flush this one. It's looking a little questionable. Kaylin, can you get me one of those orange caps over there?
Yeah, no problem.
Thank you. All right, there we go.
She has blood sugars ordered ACHS. I just checked her for breakfast, and she was 154. She's on sliding scale Lispro, but she hasn't received her breakfast yet, so she hasn't gotten her morning coverage. She's on a cardiac diabetic diet with an 1,800 ml fluid restriction and a 2-gram sodium restriction. She takes her pills whole with water. There's no discharge order in place currently, but the plan is to go back home with her daughter. She has consults with cardiology, nephrology, physical therapy, and occupational therapy. PT should be around today, and the cardiologist should be through to discuss the echo results. She doesn't have any other tests or consults currently scheduled for today, but I'll get that wound care consult placed before I leave. Do you have any questions?
No, I think I'm all set.
Mrs. Silver, do you have any questions?
Yes, when will I be getting my blood pressure pill?
That's with your morning medicines, and Mark will be back around with all of them around 9 o'clock. Is there anything else?
Yes, when will I know about this echo thing I had yesterday?
Your cardiologist should be around later today to explain everything to you. But what I could do is reach out to them now and see if they know about what time they're going to be by, so I could come back and let you know.
That would be great, because then I can have my daughter here with me.
All right, I will do that as soon as we're done giving report. So it should take about 15-20 minutes. Then I'll send out a page, and as soon as I hear anything back, I will come in and let you know. Does that sound good?
Thank you, sweetie. I appreciate that.
Okay, well, if you don't need anything else, here's your call light. If you need anything, hit that button. I will be here with you until 7 o'clock tonight.
Thank you.
That report took 7 minutes and 30 seconds, and included all the important aspects of a shift report. It may have been slightly longer than some people's average report, but think about all the added benefits that were accomplished with a couple of extra minutes. As previously noted, shift change has been proven to be the most dangerous time for patients, with the highest incidence of adverse events. With Bedside Report, you are able to perform a safety check on each patient to ensure their continued safety. This has proven to decrease the prevalence of adverse events during that time. It also has been proven to decrease the amount of call lights, which will result in less time spent responding to individual calls and allow the RN or PCT to start their day more smoothly. It allows for an introduction of oncoming staff to the patient, and it's a good time to update the whiteboard. Now you know who your patients are, and your patients know who you are, and who to ask for if they need anything. This is a huge impact on the patient's comfort level and satisfaction. They feel like they know they're being taken care of, and always knowing who is there for them allows the patient to relax to some extent. Speaking of satisfaction, Bedside Shift Report has also been proven to increase patient satisfaction scores. During a Bedside Shift Report, you can seamlessly blend the act of giving report with the act of performing an assessment. This is a huge time saver for your day. You don't need to plan to come back around to complete all of your assessments later. They're already done. Looking back at this example, a focused head-to-toe assessment was completed, and during that assessment, some discrepancies were identified, such as the difference in the wound from what was noted in report, which is a change that should have been noted during the previous shift, and with that staff member still present, she is able to validate that it is a change, and take accountability for that change by placing a wound care consult before leaving. Lung sounds, oxygen delivery, and edema findings were verified. IVs were assessed and checked for patency when appropriate, and again, if it were identified as an issue, it is an item that the previous shift could take accountability for by getting patent access before they leave. These items, along with other assessment pieces you just viewed, basically mean your initial assessment is done. If you have time between report and the beginning of MedPass, you could potentially get your assessments charted before you even pass your first pill. By laying eyes on the patient and completing that assessment at this time, you are able to set a baseline for how your patient presented the second you took over responsibility for their care. This allows you to be more alert to any changes that may occur in your patient throughout your shift. By being able to set this baseline while in the presence of the previous shift, you can also be confident that how the patient is presenting now is no different from how they've been presenting from the previous RN or PCT. Imagine going into your patient's room to pass meds. It's 8:45. This is the first time you've set eyes on this patient, and in report you were told they were alert and oriented ×4 with a general negative assessment. What you see is a slightly confused patient with what seems like slightly labored breathing. Is this a change from the previous shift? How would you be able to tell? Should you call a rapid? Call the doctor? Those are a lot of hard questions with a lot of uncertain answers. But if you had seen this patient at 7:10 when you got report, you would know, without a doubt, if this was a change from the patient's baseline or not. And that would allow you the confidence to make the right choice to care for this patient. A somewhat common occurrence amongst healthcare workers is the feeling of frustration when coming onto a shift and finding tasks uncompleted that you feel like should have been done during the previous shift. This is an issue of accountability, and Bedside Shift Report can be a powerful tool to counter this issue. Bedside Shift Report allows the oncoming shift to visualize the patient, medical interventions, equipment, and the room. It's the opportunity to see if the Foley is emptied, if the IV has gone bad or the IV bag is about to run out, if the patient has been cleaned and well taken care of, or if the room is a mess. And address these issues in real time with the previous shift. Ask them to order a new bag of medication before they leave, or respectfully call out messy items in the room that need to be addressed. Okay, so I noticed the Foley bag in there is about to burst. There's garbage all over the floor and the trash is about to overflow. Ah, crap, and I think the bed alarm wasn't on either. Anyway, I would never want to leave a room like that for you. Could you please deal with that before you go?
Yes, I'm sorry. I'll take care of that right now.
When it comes down to it, performing Bedside Shift Report is a requirement of all RNs and PCTs at Trinity Health Livonia. So you need to do it. But it is a change in the practice for most of the staff here, and with any change, there will be some resistance. People will come up with various reasons and excuses to avoid adopting a new process. Some will be unjustified, but others may have some truth behind them. But, as it was shown in this video, there are strategies and techniques to overcome these issues to allow you to perform an effective, safe, and time-efficient shift report at the bedside. When everyone works together to perform Bedside Report consistently, it is proven to improve staff workflow, patient satisfaction, and patient outcomes. It's never easy to change a practice, but when the results are so overwhelmingly positive for both the staff and the patients, it's worth the work it takes to overcome these barriers.